All right, let's talk about something you see pretty much every single day at the pharmacy counter: acute bronchitis. In this explainer, we're going to arm you with all the practical, evidence-based info you need to counsel your patients, handle those tricky conversations about antibiotics, and really provide the best care. So let's jump right in.
Here's the game plan. We'll kick things off with what acute bronchitis actually is. Then, we'll get into your role in spotting red flags. We'll debunk some common treatments that don't work and focus on what does bring relief. We'll also tackle that big one, the antibiotic conversation, and wrap up with how to set patient expectations from the get-go.
First up, what exactly are we dealing with here? Really understanding the nuts and bolts of acute bronchitis is the absolute foundation for any good patient counseling.
Let's start with the single most important number on this topic: over 90%. That's right, more than 9 out of 10 cases of acute bronchitis are caused by a virus. This one fact really dictates our entire approach to treatment. It's everything.
So that's the clinical definition, right? But with your patients, I found it so much more helpful to call it a chest cold. That simple phrase immediately helps manage their expectations. It frames it as a self-limiting viral thing, just like a head cold, but, a bit lower down in the chest.
And here it is, the classic misconception we have to tackle head on. A patient comes in and says, "But my phlegm is green. I need an antibiotic." And we have to be ready to explain that no, that's not how it works. That color is just a sign of their white blood cells doing their job fighting the inflammation. Bottom line, color does not equal bacteria.
Okay, so knowing it's almost always a virus helps us with our next crucial role, which is basically triage. It's all about knowing when you can reassure a patient and when you need to send them to a doctor for a closer look.
Think of this as your quick mental checklist. If their vital signs are pretty normal, heart rate under 100, breathing rate under 24, temperature under 38 Celsius, it's likely just uncomplicated bronchitis. But the big red flags that might point to pneumonia are a high fever over 38, or if the patient mentions any rattling in their chest or feels short of breath. That's when you refer.
All right, now for a little rapid-fire round. This section is all about giving you the confidence and the evidence to say no when patients ask for things that just, don't work. Let's just be super clear here. For your standard, uncomplicated acute bronchitis, the evidence just doesn't support using any of these routinely. Not antibiotics, not steroids, not even beta-2 agonists unless the patient has asthma or COPD. And, this one surprises a lot of people, the evidence from eucalyptics and expectorants is really weak. And just to really drive the antibiotic point home, a huge Cochrane review found that, at best, they might shorten a cough by about 12 hours, half a day. When you put it like that to a patient, balancing all the risks for a tiny 12-hour benefit, the decision gets a whole lot easier for them to understand.
And here are those risks, put into a number. The number needed to harm is 24. That means for every 24 people we treat with antibiotics for bronchitis, one of them is going to have an adverse effect, like nausea, diarrhea, a rash, you name it. The risk just clearly outweighs that tiny, tiny benefit.
Okay, so enough about what doesn't work. Let's pivot to what does. This is your toolkit. This is how you can provide genuine evidence-based relief and care that actually makes a difference.
Honestly, the foundation of care starts right here. This stuff is simple, but it's often the most effective. Advise your patients to get some rest, stay away from smoke, maybe use a humidifier, and wash their hands to avoid spreading the virus around. It's basic, I know, but it's so crucial.
Now for your go-to over-the-counter options. For acetaminophen, you're always checking for liver issues. With ibuprofen, tell them to take it with food and just be mindful of any kidney or heart problems. For dextromethorphan, the big thing is screening for drug interactions, especially with SSRIs and MAOIs. And honey, it's a fantastic option, but the absolute #1 rule is never ever give it to a child under 1 year old because of the risk of botulism.
And now, we've arrived at what can be the toughest part of the job, the patient who is absolutely convinced they need an antibiotic. But let's try to reframe this. It's not a confrontation. It's an opportunity to educate.
This is so important to remember. The research is crystal clear. A happy patient isn't one who walks away with an unnecessary prescription. A happy patient is one who feels like you listened, you understood them, and you gave them a clear explanation. Your communication skills are your most powerful tool here, by far.
So here's a simple 3-step script you can use. First, explain it's a chest cold caused by a virus, and that antibiotics just don't kill viruses. Second, briefly mention the downsides, both the personal side effects and the bigger issue of antibiotic resistance. And third, immediately pivot to what will help them feel better. Focus on all those symptomatic relief options we just talked about.
All right, our final and maybe most important strategy is managing expectations. A patient who knows what the next few weeks might look like is way less likely to get frustrated and come back looking for antibiotics.
This timeline is such a powerful tool. You can tell them, look, your symptoms are probably going to be at their worst this first week, but the average time it takes for the cough to go away is actually 18 days. Letting them know it's totally normal for a cough to stick around for 3 or 4 weeks, maybe even longer, is an absolute game changer. It prevents so much anxiety.
So let's just end with this thought. Every single conversation you have with a patient about a simple chest cold is an act of antibiotic stewardship. By educating one person at a time, you're not just giving them great care, you're actually helping to protect one of the most precious resources we have in modern medicine.